Well, I mean, certainly anything's open for discussion with regard to these webinars. I'm happy to tell you what I can, and this particular topic is about PGD and its many applications and uses, as well as try to touch on some of the good points and bad points and various techniques, because PGD encompasses it stands for pre-implantation genetic diagnosis, now often referred to as PGS, or pre-implantation genetic screening, and that has various techniques in the laboratory you may be aware of. We used to do something called FISH, or fluorescent in situ hybridization, and now we mostly utilize various forms of CGH, which stands for comparative genomic hybridization. And the newer techniques usually use CGH in one form or another. And there are several methods of doing this. And there's even other variances of this CGH that I won't bore you with, but in essence, most of them are considered to be equivalent with the various techniques that they use. So CGH is kind of lumped into a single category that in most technologies, most laboratories use the same techniques. But within these things, on the IVF center side, there are different ways of doing PGD or CGH, and one is the polar body biopsy, and then there's something called day 3 embryo biopsy, and lastly, now the blastocyst biopsy is gaining favor. Have you ever had IVF before?
Yes.
And have you done genetic screening or testing before?
Couple of times. Yeah, actually, I just had a failed IVF cycle, and there we done PGD on day 3 embryos, the FISH technique, because we want to do the gender selection.
I see. Okay. Well, we'll certainly talk about that. Embryo aneuploidy, just looking at this first slide here, is the single most important issue that affects human reproduction. And this is just abnormalities in the chromosomal number. And sometimes the sex chromosomes, X and Y, can be involved in aneuploidy, Down syndrome being the most famous, but there's a multitude of various combinations of embryo aneuploidy. And usually the issue starts with the egg. So primarily the egg determines the embryo competence, and the chromosomal abnormalities that are within the egg lead to embryo aneuploidy. However, the sperm factor is a significant issue, and I don't know how to minimize this thing here. There we go. And the sperm factor is gaining a lot of importance, as we now know, because the non-chromosomal abnormalities within the sperm that can be selected with ICSI don't necessarily lead to chromosomal problems in the embryo, but they can lead to abnormalities that cause embryo failure and are undetectable by current screening techniques. So sperm factors, we now know, are quite significant in leading to embryo problems. And the frustration is that we can't determine these problems in the embryo itself. This slide just kind of shows, underlies the issues that we see with egg abnormalities and abnormalities in the embryo itself, is that as we get older, the percentage of live births decrease, as you see here on the left, and progressively the birth rate goes down as yes, and the number of miscarriages goes up, again related to mostly this egg/embryo factor. The reasons that people do PGD, and this is kind of what you're interested in talking about to some degree, is the aneuploidy screening, looking for chromosomal abnormalities, female age, recurrent pregnancy loss, prior IVF failure are kind of often reasons that people want to talk about these things. And certainly that is one of the main reasons that people do CGH or PGD in general. Looking for single gene defects like cystic fibrosis and things like this. Yep. There's many different, that certainly is a very effective method of looking for abnormal embryos. And sometimes current techniques allow us to do both, look for chromosomal abnormalities and single gene defects and other genetic disorders, translocations and things like this that are pretty uncommon. People who are interested in a single embryo transfer, either for medical reasons because of things, medical diseases like diabetes or things where twins might be a real problem, or if there's uterine abnormalities, for example, that's where the uterus just simply doesn't have the capacity to carry twins, for example. And then, of course, gender selection and various reasons people do that for gender-associated diseases, and also for patient interest, looking for family balancing or just whatever reason they might be interested in having a boy or girl. And, here's just a picture of a couple of blastocysts, and just underscores our inability to determine which ones are chromosomally normal or good ones by visual inspection. And this has just always been a problem, the hope and promise of CGH screening or PGD in general is to be able to improve our ability to select which one of these might actually make a baby and allow us to do single embryo transfer or only put back ones that have the best potential, and minimizing the risks of multiple pregnancy especially. To some degree these techniques have fallen short in achieving that goal and that promise of selecting the quote good ones because of the fact that there are so many limitations in determining genetic abnormalities in embryos with the current techniques, and a significant proportion of embryos that are abnormal go undetected. And the two main things are genetic abnormalities, as I was saying, and DNA fragmentation, but also things like mosaicism, if you've ever heard of that, where there's a mixture of chromosomal normal cells and chromosomally abnormal cells in a single embryo. Our ability to look at an embryo and tell that it's bad and is incapable of making a baby, our ability to determine the bad ones is very good, actually. Visually. So when we look at embryos and apply the techniques that we've had for so many years in microscopic examination, we're very good at telling which ones won't make a baby. But our frustration is always trying to then determine which ones will by visual examination, which just unfortunately, as I said, falls short. The primary technique that you're familiar with now is the day 3 biopsy, and this is kind of been the long-standing gold standard of how we look at the chromosomes. We're a single cell here in the picture. You've probably seen similar ones before. Each cell, in theory, has a single nucleus, and in this particular cell right here, if you can see my screen. That cell, you can see a single nucleus right there in the middle. In the middle, yeah. And, that's kind of a little bit tricky on some of these. It's kind of hard to see. But, if it has a single nucleus, then, of course, that's in theory, you're able to select that embryo, or pardon me, that's one of those cells, and determine the chromosomal normality of the entire embryo by sampling the one cell, leaving all the others, and this one cell that's being extracted in theory then is the same as all the others. And, you know, most of the time that's true. So if that one cell that's sampled is abnormal, then the other ones are abnormal as well. However, mosaicism is a situation where the single cell that you sample is abnormal, but all the other ones, or a significant proportion of the remainder, are indeed normal, or vice versa. The sampled one is normal, but all the other ones are abnormal. And the resulting blastocyst, when, you know, this particular embryo might be 7 or 8 cells, but a blastocyst might be a couple of hundred cells. And, you know, this problem of mosaicism, where you're trying to have one sample represent the whole, is fraught with some difficulty because of this condition where there's a mixture of normal and abnormal cells. It's pretty good, but mosaic embryos are thought to be one of the main reasons that, you know, otherwise normal biopsy embryos fail. Now, blastocyst biopsy is gaining favor, and, you know, what they do is they sample, you know, maybe half a dozen cells from this outer shell here called the trophectoderm. The T over here stands for trophectoderm, and this is what ultimately becomes the placenta and gestational sac that surrounds the embryo. And the embryo is this mass of cells here called the inner cell mass. So this is what makes the baby, and this makes the placenta, the umbilical cord, and all that other non-baby tissue that's involved with the pregnancy. And sampling half a dozen cells here gives you a more representative sample of what would become a viable pregnancy. And the theory is that the mosaicism factor is going to be reduced, and indeed it seems to be in preliminary evaluations true. You know, just with respect to gender selection, I mean, it's you know, there's several purported but controversial benefits of this process, and, you know, it's, again, was hoped that it would improve IVF success rates. It hasn't really made a significant impact there, but hard to tell why that is. Many reasons, I'm sure. Reduces miscarriage rate. That's probably true, but the miscarriage rate with IVF in general is lower than traditionally seen in other conceptions. But you know, just the process of IVF itself reduces the probability of miscarriage. In fact, it is really used to treat patients who have recurrent pregnancy loss. IVF itself, with or without PGD screening, and it minimizes aneuploid birth, defects like Down syndrome, but obviously those are so rare anyway that in the majority of Down syndrome babies or abnormalities in babies are born to women who wouldn't get screening anyway. So the proportion of Down syndrome births that would be prevented by this technique are you know, really low. Because IVF Down syndrome pregnancies are just rare anyway. But that said, you know, they certainly fall short on that idea, and it just is not really a good reason to do that because of the fear of Down syndrome. But the reducing of multiple pregnancy is probably a legitimate thing if you do a single embryo transfer. But of course, the probability of birth itself is going to be reduced when you put a single embryo in versus two embryos, but nonetheless, that is probably a legitimate point. And certainly for gender selection, I think there's really no controversy that PGD is the optimal method, and really is the only method that exists that's accurate these days. The sperm selection method.
PGH is not that good for gender selection?
No, it's very good. It's the best.
Okay.
So CGH, really is the best method for, well, I won't say CGH. I mean, I think FISH that you did is probably just as good. And, the problem with FISH is that it depends. I mean, if they did what's called if they did a FISH with probes that select every single chromosome, then that's one thing. But it's called a 24 chromosome FISH. And most of the time, people don't do that. They use either a 9 or 12 probe, or possibly even just a sex probe.
Yeah, we did 5 probe.
5 probe, yeah.
We did check SY and 13, 18, and 21.
Yeah, and that covers some of the more common ones, but probably leaves out in the neighborhood of 50–60% of chromosomally abnormal embryos that would otherwise be deselected if you did, for example, a 12 or a 24 probe FISH. So FISH versus CGH is to my knowledge, really, they're probably equivalent in what they're supposed to do, in their accuracy. And certainly, even a 2 probe FISH for just X and Y is going to be extremely accurate for determining gender. But the problem is that it just leaves out all the other abnormalities. So people often think that, hey, I got all these normal embryos. Well, you'll get the embryos that are the proper gender. That's pretty certain. However, a lot of those embryos are going to be abnormal.
Abnormal, yeah.
That's kind of the problem. So most of the time, FISH is just not something that's used anymore. I mean, I honestly haven't done a FISH case in several years once CGH came of age, and because it's certainly for aneuploidy screening or chromosomal analysis, like what you're interested in.
So with CGH, you have to do frozen transfer, right? You can't do the fresh cycle.
Oh no, sure you can. Yeah, sure. They're all done. Oh, well, I mean, there is a lab that's outside the country that I'm only aware of one organization that uses that lab that's in Turkey, but everybody else that I know uses labs that are within the United States, and you get the results back the next day.
Oh, really? So it means if you do a CGH on day 5 embryo, still you will be able to do the fresh transfer?
Yes, yes. Yeah, you can if you do a blastocyst. It depends. There's only a few places that are doing that. But it is possible. It's just not something that's widely available by any means.
Okay. And, so in Colombia, at your center, do you offer CGH?
Yes. I mean, CGH it's not really done on site. What we do is we send the embryo off. The blastocyst biopsy doesn't really have any benefit over the traditional day 3 testing, for gender selection.
But in our case, we do the gender selection and we put 5-day too early blast, but still I didn't get pregnant. Well, I have the positive pregnancy test and the HCG is rising very, very slow, and then at the 6-week ultrasound they just saw the sac, but it was empty.
Yeah, these are related to chromosomal abnormalities, and the empty sac, if it truly was empty, is an abnormality of the blastocyst.
So if you have abnormal eggs, like if you are getting too much injections, the FSH and the high doses of injection, if your eggs are not good, then you don't have good embryos, right? Is that the case?
Well, the abnormalities of the eggs aren't thought to be related to the dosage of the FSH necessarily.
Okay.
So, I mean, how old are you, just for example?
My age?
Yes.
31.
And so in a person of your age, I mean, 9 out of 10 embryos is abnormal.
Oh, really?
So, Yeah, it's a very, very common problem. I mean, this is exactly what we were saying at the very beginning, is that, the vast majority of embryos don't make a baby. And, that is almost always related to an inherent embryo problem. And almost always that inherent embryo problem is aneuploidy. But, even in a young person even an egg donor, I mean, so an egg donor, for example, is 28 years old and has 15 eggs. I mean, that couple who receives those eggs, they might have one baby. And, the other 14 eggs don't make a baby.
Mm-hmm.
But that doesn't mean that that egg donor's got an egg problem. It's just the way it is, that most eggs are abnormal and most embryos are abnormal. And as a result, I mean, this is exactly why we do multiple embryo transfers and why you try to get a lot of eggs.
Mm-hmm.
So, this is not really what you're asking about the FSH, but, there is this thought out there that taking low-dose medications, reducing the number of eggs, somehow makes them better. Well, it's just simply not true. I mean, these low-dose protocols, the pregnancy rate is a lot worse than traditional dose protocols because of the fact that you don't get as many. So a 31-year-old person who gets 12 eggs is always going to have statistically a better chance than a 31-year-old patient who gets 5 eggs.
Mm-hmm.
So, I mean, there is a plateau. There's a point at which more eggs is not better. And it seems to be around the number 12 or 15. So in other words, a patient who's 31 years old that gets 25 eggs has about the same pregnancy rate as someone who's 31 years old and gets 12 eggs.
Okay.
Now, here's what your problem is that, the misconception is that, well, I have 25 eggs and, I have 8 blastocysts and, I didn't get pregnant.
Mm-hmm.
And then you do 3 frozen embryo transfers, and finally there is a pregnancy and 1 baby. Okay, well, great. But that's a lot of work and a lot of cost and effort and all those things to finally get to the baby. And the conception is, or the idea, I should say, is 25 eggs, 1 baby. Well, the medicine took too much medicine and all those eggs were abnormal because I took too much medicine. Well, I don't know what the, 1 out of 25 is statistically not that much different than 1 out of 15. So the 15 egg patient has 1 baby also, but the 25 egg patient has 1 baby, but 10 extras were abnormal. So, they've just gone beyond. It's sort of a point of diminishing return after 15. I mean, I've had a patient who had 80 eggs one time, and she had 20 blastocysts, but she had twins, and nobody complained about it in the end. But, the point is that still the vast proportion of embryos were abnormal, but she still ended up with 2 babies. And, so there's a point beyond which more eggs is not better as far as probability of pregnancy. But, that person who's got 80 eggs and 2 babies, I mean, you might think, oh, my God, all that medicine. But you know what? She took a low dose of medicine.
Oh, really?
She just, had polycystic ovaries, so had a propensity to get a lot of eggs no matter what you do. So anyway, I mean, it's this sort of phenomenon that's all about numbers, and it kind of fools us into thinking that it's the medicine. But, I think it's this concept of diminishing returns beyond a certain number, and that's really what the issue is, and it's not the medicine per se.
So it means if we don't get pregnant this time, the reason is that there may be some chromosomal abnormality that didn't check by the fish technique because they
Exactly, yeah. I mean, that's almost certainly the case. assuming there's no male factor.
Yeah, my husband, he just has very low sperm count, so he just have frozen sperm.
Yeah, I mean, so there's an issue right there. I mean, you know, there's no question that when there's a male factor, a severe male factor, the pregnancy rate with IVF and traditional ICSI is lower. And, you know, why is that? Well, because the probability of selecting an abnormal sperm is high, even with traditional ICSI. You know, so if I say the pregnancy rate is 35% in cases like this where there's a severe male factor, the pregnancy rate, if there weren't a severe male factor, is closer to 50 or 60%. So it does diminish the fact, and that's just because of the sperm factor itself. But the problem is these aren't sperm abnormalities that can be detected by CGH. So the sperm abnormalities that contribute to abnormal embryos are undetectable by CGH. There are DNA fragmentation and other issues, we believe, and you know it may increase the risk of aneuploidy as well. So some of these things might be detected, but a lot of them probably are not detected by traditional CGH or FISH. And, you know, as a result, the embryo looks normal and tests normal, but doesn't make a baby. And, you know, it's because of these other factors that are more common. So, you know, the best treatment is to select sperm in a different way besides traditional ICSI, and specifically referring to something called HRSS, also called IMSI. So, you know, that's something for a different lecture maybe, but it's a great topic. And, you know, I don't know if he had a DNA fragmentation test.
No.
It might be helpful. And why are they using frozen sperm?
Because he has very low sperm count. So they just do the procedure and take out the sperm in 2007, and then we use the frozen sample afterwards in 3 or 4.
So this is a testicular biopsy?
Yes.
Yes. I mean, the best thing to do is to, yeah, I mean, this is a long discussion, but, you know, this is a significant problem that relates to the probability of success, and especially when you use frozen testicular biopsy. So, you know, the quality of the sperm is affected tremendously by that process. You know, the entity of low sperm count itself, the testicular failure, and also the cryopreservation of the sperm, or pardon me, testicular sample is not the optimal way to do it. I mean, if you're going to use a testicular sample, it's better to use a fresh sample and to do something called a testicular sperm aspiration, or a TESA, T-E-S-A or T-E-S-E.
So in case of TESA, you recommend a fresh sample, frozen is not good?
Yeah, if I had my choice, I'd use a fresh sample for sure.
Okay,
it's always better.
I never discussed this thing that sperm has an issues too, and sperm abnormality or anything. Mostly they just discuss the egg-related issues.
Of course, I mean, but you know, I mean, your eggs are no worse than anybody else. And I've already described the fact that most eggs are bad anyway. You know, but you don't have some global egg problem. I mean, that's extremely rare. But you know, it's possible, but it's extremely rare. I mean, I think I've seen it once or twice, but not very often. And, you know, the sperm factor is a huge problem.
Okay, and you are telling me if we do CGH, still you won't be able to find, because they check all 23 chromosomes, but still they won't be able to find the problems related with the sperm?
Well, they'll be able to determine most of it. I mean, certainly it's helpful. I mean, to do I mean, if you're doing gender selection, then if that's the primary reason that you're doing the CGH, then that's one thing. But to do CGH for because of the severe male factor, that's a little different. I wouldn't necessarily recommend it for that reason.
Okay. So can you do CGH on frozen embryos?
Well, I'm gonna say no. I mean, it's not recommended at this point in time.
Okay.
Yeah, I wouldn't recommend it.
But I still don't understand that if you're doing a day 5 blastocyst biopsy and do the CGH, then how you will be able to get the results so fast that you will do a
Well, I admit, I mean, it's something that is not readily available. I mean, I was more referring to the possibility of can it be done, and the answer is yes, but it's not something that is available in 99% of IVF centers, I would guess. I mean, we don't do it, but, it's been done before in study circumstances. It's going to be available, sometime in the next few years to widely, but right now it's something that has to be shipped off, and that can't be done overnight. If you're talking blastocyst, if you're talking about a day 3 biopsy, then certainly, yeah, I mean, it can be done overnight. It has to be shipped off still, but that's fine. It can be.
So does in case of PGD, when you do a day 3 biopsy on 8-cell embryo, does it cause any damage to the embryo?
Well,
because
this is a bit.
We always have like expanded or hatched blastocysts, but this time we have 4 early blastocysts, which they transfer to and they freeze to.
It's really controversial. My personal opinion is it's possible. But, the traditional thinking that you'll hear out there is it doesn't affect the potential for blastocyst development, but, it's really hard to prove that. And, it sort of concerns you. But then again, blastocyst biopsy does as well. I would think that any time you're slicing open an embryo and taking out cells, it has potential to affect that embryo's implantation potential and its competence. But how do you determine that? I mean, all you can do is compare success rates, and success rates are a difficult way to compare anything, the outcomes. And so with that said, I mean, it's tough to say is a day 3 better than a blastocyst, with regard to embryo damage, if probably not. But, the question is, does it damage the embryo at all? And probably very little. But, it may. And it may affect an otherwise normal embryo. But when you're doing these things for gender selection, you have no choice. You have to do one or the other. But I don't think a blastocyst biopsy is any better than a day 3 would be, when you're thinking only about, quote, damage.
Yeah, but when I talked to my doctor, he said that because on day 3 there are only 8 cells, and on day 5 there are more than 100. So when you take out from blastocyst, it won't cause much damage to the.
Well, I mean that's an interesting theory, but there's just no way at all to say whether that's true or not.
So in our case, where we have a failed IVF with day 3 PGD testing, what do you recommend next time? To do CGH?
For sure.
There are all other chromosomes?
Yes, for sure. That's the way to go.
Okay.
I mean, I have to assume that you really want to do gender selection.
Yeah, because we already have 2 girls with 2 IVFs, and That one is the last try. So we really want to this time.
Yeah, I mean, I think the things that you can...
4 frozen embryos, 2 we know are female, and 2 we don't know the sex. So I'm just confused whether to do a frozen transfer with those embryos or to do a fresh cycle and do CGH or gender selection. I don't know.
I mean, I think if it's that important to you, then if it's that important to you, then of course you wouldn't want to take the chance.
Yeah. But
transferring to, I assume they didn't.
As compared to frozen, it's so much effort involved, especially with the kids. And I already met you two in St. Louis.
Oh, did you? Okay.
Yeah, we had a consultation with you, and by the time we decided that we want a date for the IVF, I found out that you left St. Louis.
Yes. Yes. Well, so I have an office in St. Louis, but the fertility center is in Columbia.
Okay, and you have an office in St. Louis too?
Well, for gynecology and basic things like that, but to do IVF, we are in Columbia.
Okay.
Or Tulsa. We have an office in Tulsa too.
Mm-hmm. So at my age, I'm 31, and they did L5 protocol. I think you are familiar with that.
Yes. Mm-hmm.
I think it's a good protocol, or a little, or L4.
Yeah, I think so. I mean, how many eggs did you get?
They get 20 eggs and 13 were M2s, mature ones, and then 10 fertilized, and then 8 embryos. They said 2 were abnormal because they are growing too fast. They are 10 cell or 12 cell on day 3. So 8 embryos for biopsy on day 3. And the biopsy report came that 4 are normal and 4 are abnormal. 2 girls and 2 boys. So female ones we transferred 2 early blasts, the boy ones, male ones. But I have that positive pregnancy test, but slow rising betas, and a 6-week ultrasound shows empty gestational sac, so I have to do a DNC at 8 weeks.
You did do an DNC already?
Yes.
Yeah. So
so I don't know what went wrong, because on the previous successful IVFs, I have low dose injections of FSH, pure FSH, polystem, nothing else. But this time I am on L5 protocol, little higher doses, 375 and 20, and they have, I know that there are 18 and 20 milliliters, and then they give the trigger shot at the so I don't know what went wrong. The eggs were not good, or probably I have many chromosomal abnormalities.
I mean, I think the it's hard to speculate. Of course, if I had to pick try to guess on what the reason was, I mean, probability that the embryos were abnormal with chromosomal problems.
Mommy.
And that's why they're not expanding, and there's no information about the chromosomal status. But that's far and away the most common reason. That the embryos don't develop properly and fail to plant. I mean, I just can't think of any other reason why it wouldn't work.
Okay, so you think so the LF protocol or the higher doses of FN working with the normality of the embryos?
Well, I don't think so. I don't think do you need to be on an L5? Probably not. If only 13 were mature, you don't need to get 20. I mean, there's nothing.
Yeah, but
so you could probably take a lower dose and still get a dozen eggs. I think that would.
I did L4 and still get like one time 14, one time 11.
Yeah, that's exactly what I'm saying. I mean, but there's not a big difference between an L4 and an L5 on the total dosage of medications, and so. I mean, I think it just all underscores the point that I'm making, is that, the dosage of an L4 versus L5 is very similar, And, I wouldn't qualify L5 as high dose and an L4 low dose. I think that they're essentially the same, a little bit more with an L5. And, the male factor, is going to be a significant effect on the embryo status. So, let's just assume that I'm correct about 9 out of 10 eggs fail to make a baby. Well, the point being is that when you have a severe male factor, the probability of that one good egg getting a bad sperm is pretty significant. And, that bad sperm has a significant influence on the potential of that embryo. And, that's the problem, is that if you have 10 eggs and you have 10 grade 1 sperm, every egg gets a good sperm.
Yeah, that's right.
As best as humanly possible.
We do fresh cycle this time. We use fresh sperm, not the frozen ones.
If at all possible, yeah.
Then he has to go again for a procedure like the.
I'd have to know more about it. I'd have to look at the information and to determine how the biopsy can be done, because there's different ways to do it.
Okay.
I just don't know enough about the male factor and to comment, but I'd have to look at some of that information to determine, it's a complicated case, because, the male factor affects everything. And, when you're doing gender selection, you're automatically reducing the probability of having even one good embryo by 50%. So that complicates the problem. You could have a CGH normal embryo. You could get 15 eggs and, to have 10 day 3 embryos that are worthy of biopsy, and of those 10 embryos have, one that's normal and male. And it's distinctly probable that there will be 0 that are normal and male.
Male, yes.
Because when you inject gender selection into the scenario,
yes, that's right,
you're automatically, because they're, again, the probability of getting one baby out of 15 eggs, male or female, we'll just say is 50% in a case like this.
Yeah.
Well, you're cutting it significantly from that 50% by doing CGH and gender selection. That's just a statistical fact. And, getting a good number of eggs with a, reasonable protocol is in your favor. But it still has a significant impact on the overall probability of success. And that's just the problem. But, that's just, again, I'm not trying to belabor, or talk you out of gender selection. I think that's your prerogative. But it's ultimately, it just complicates the issue. So you have these factors of the male factor, which, the reason you're doing the IVF, that compromises things in and of itself. And then you're just taking that reduced probability and magnifying it by doing gender selection. So it's a tough case.
When we find out about the male issue, they told us that he has azoospermia and there is no sperm in the ejaculation, but everything with the sperm is fine when they take out the sample. Every stage.
Well, what that means is that there are sperm that are moving. So it depends on why there's azoospermia and,
Yeah, that's what we don't know. They didn't figure it out.
Yeah, well, they would have if they did a biopsy.
They did a testicular biopsy at that time. It's years back, but they did it.
Yeah, you'd have to look at that pathology report.
Okay.
But that would be useful information to know. That's an interesting case, but I mean it's complicated because you know, these factors do affect the probability, and I mean it all just means that, you know, the chance of having success with a single IVF is significantly different than if you're, you know, if there is no male factor doing gender selection.
Okay, I understand.
I mean, it just means that, you know, as a result, it just requires more efforts.
Mm-hmm.
You need more opportunities to have the chance of success. As a couple, and just, you know, for family balancing,
Mm-hmm.
you know, where there is no problem per se, right?
Yes, I understand the point.
Good. Well, hopefully helpful, and I appreciate your time.
Yeah, sure. Thanks so much.
If you want to chat with me about getting these things at or review information, do so, and refresh our memories about that stuff, and, you know, give you some advice if that's of help to you.
Sure, will do.
Happy to do what I can.
Okay.
All right. Well, thanks so much, and we'll be around and available if there's anything we can do.
Sure. I'll probably
Okay.
take an appointment with you in Colombia.
Well, I can chat with you anytime on the phone. You don't have to leave the comfort of your home.
Okay, good. That's great.
All right.
Okay. Thank you so much. Thanks for your time.
All right. You bet. Thanks to you. Bye-bye now.
Bye.
All right. Dale, well, thank you.
No problem. We had one more person on for a while there, one of the other Indian girls. So,
Yeah, I saw that. Yeah.
So, yeah.
So, interesting.
I will edit this.